Hi there, my name is Alex Borzak, and I'll be talking about emergency preparedness today. So basically what we're going to do, introduction to preparedness. So these are more or less the objectives, what the main points I'm going to be talking about. We're going to talk about natural disasters versus man-made disasters, what the difference is. Talk about levels of emergencies, there's several different of those. And then also emergency operation plans, specifically kind of how more they deal with the healthcare setting. We're going to get into some other areas as well, but we're going to try and focus more on the healthcare aspects since this is a bunch of nurses that is in this class. So under that, there's three main levels that we're going to talk about is provider notification, hospital preparedness, and hospital response, but also just in a general emergency response as well. You kind of have to talk about that at the same time. So types of disasters. There's two main different types of disasters that for our purposes we're going to examine here. Natural disasters and man-made disasters. So natural disasters are exactly what you think of it. Floods, hurricanes, earthquakes, snowstorms, or blizzards. I mean, everyone knows Hurricane Sandy. Everyone knows Hurricane Katrina. Those of us who are older may remember Hurricane Andrew back in the early 90s. Devastating natural occurrences. Earthquakes, California most notably has those because of the location that they are to the San Andreas Fault. Those types of things. Blizzards, we've had a few of those in recent memory. Again, kind of going back to my childhood back in the 90s, and the blizzard of 92, blizzard of 93, still fresh in my mind. Man-made disasters include war, nuclear disasters, bioterrorism, global warming, and power grid failure. Now, with the last two, global warming, I'm not trying to spark any debates about whether it's an actual thing or if it's not. It's still considered by governments to be a disaster which can global warming can affect natural disasters, severity of natural disasters, particularly tornadoes, hurricanes, flooding, those types of things. But also global warming in the sense of scarcity of resources, scarcity of water, scarcity of oil, things that may precipitate war between countries or at least or raise tensions. And then also power grid failure. This kind of comes into, again, it can be a part of a natural disaster where power grid or there's other catastrophic failures that are caused by natural disasters. But there's also man-made disasters that are specifically isolated to the infrastructure of a community, infrastructure of a state, infrastructure of a particular reason. Power grid is the big thing that is focused on, especially during in local and regional communities. Then we get into the levels of emergencies. There's really three for our basic discussion here. Level 1 was just is a local response. Level 2 would be a regional response. Level 3 would be a statewide or national assistance. And when we talk about NIMS and the National Response Framework, towards the end of this presentation, you'll find that there are certain protocols and procedures that you need to go through and certain things that you have to obtain first before you can actually activate resources at the statewide and at the national level. And then you get into how those resources are utilized and how that supervision of resource utilization is managed. And that's all within the incident command framework. So here we are into our second big chunk of the presentation. That's the emergency operations plan. And that's exactly what it is. If there's an emergency or if there's a straining of resources, these plans become activated in order to mitigate the downward effect of loss of resources, loss of supplies, overburdening the system, whether it be a healthcare system, whether it be a regional system, whether it be a city system, what have you. For our discussion, a lot of it's going to focus on the hospital system or the hospital network system. So first of all, we get into provider notification, and this means means more or less public health and epidemiological notification, because the providers are the ones that are going to need to know this information as far as, say, for example, there's a foodborne illness outbreak in a particular area, and this is important for primary care and providers to know, important for emergency physicians to know, because it's going to, if it increase the amount of patients that the providers are going to see and that the providers are going to have to treat. If you get into like 2 or 3 people with foodborne illness, not that big of a deal. But if you get a restaurant, 50 people a day for over 3 or 4 days, there's 150 to 200 people now that you have to deal with this foodborne illness, whatever it may be. Whatever support they're going to need is going to be maybe symptomatic management. They're going to need rehydration, those types of things where they may have to be admitted to the hospital. This is going to be a huge strain on the healthcare system. So several models have been introduced to inform providers of current threats, and of course, as always, talks about bioterrorism threats as well. But for our discussion at this point, we're going to just focus on the major epidemiological incidents that you might see, whether it be foodborne illness or like antibiotic resistance bacteria that might be popping up in a particular area for a certain amount of time. But anyway, several models have been introduced both at the federal and state level, going directly to the public health people within the community, which then is going to be responsible for disseminating that information to the healthcare providers. There's also other things such as listservs, text messaging that go directly to the providers themselves. But from the studies that are out there, there has been kind of an ad hoc, coincidental explanation showing that these things may work, but then when you go and actually survey the physicians about how often they actually receive this data, excuse me, how much they actually receive, if they actually receive this data, and if they do, how much they actually implement it, it's very, very minimal, if at all. So again, data collection, this is important for epidemiological tracking and response, not just at the state or local public health service levels, but also within the practices themselves, because they're the ones that are going to be dealing with this head on, and they're going to be responsible for treating the patients. Their health system that they're affiliated with is going to be responsible for carrying the burden of care for these patients. And if you're in a small rural system, or even here in Lancaster, this system here, it can become overwhelmed very quickly. Look at the flu that we have going on right now. How many times have we hit high capacity protocol within the last month and a half? And again, no one system has been proven beneficial, but as research geeks like to do, they will continue on forthwith and try and find an applicable method to disseminate this information. Hospital preparation. Again, I kind of mentioned a little bit. Here at Lancaster General, we've hit high capacity protocol several times throughout the last month and a half, mainly because of the high admission rate because of the flu, which is typical for this time of year. Imagine that if this weren't the flu, and imagine if this were a foodborne illness that affected several restaurants within the city, or imagine if this were a bioterrorism, or if this were a natural disaster event that would cause a higher, much higher than normal influx of patients to the hospital and strain those resources. The study that I read is that that I looked through here, I have the citation at the bottom. Planning doesn't encompass not just disasters, but it also encompasses everyday things such as flu outbreaks. It encompasses everything such as foodborne illness outbreaks, like we've already talked about beforehand. Then you have to account for the high census due to common illnesses, because oftentimes these things may be somewhat overlooked, but they are just as important. Hospitals are required to have policies and procedures in place, but the study that I read, there's a very low level of coordination within the hospital and even less between community resources. It varies between institutions. Here in Lancaster, we're lucky we have a fairly high coordination between community resources and the hospital. They've done a very good job of planning for other bioterrorism incidents, planning for Ebola outbreaks, and conducting needs assessments as necessary, as well as drills. Which brings me into the next section, the response. And this varies depending on the type of disaster and the need within the community or within the area. A mass casualty incident with or without need for decontamination before treatment is also a big consideration. Where is that decontamination going to take place? It doesn't necessarily always get done in the field where you're extricating patients. Sometimes they get shoved in the back of the ambulance and they're outside of your hospital and they still need to be deconned. What resources, what areas are available to do a mass decontamination? The research that I read through, the article put out 6 lessons that can be gained from studying man-made disasters, Chernobyl, 3 Mile Island, Fukushima, and they came up with these. Lesson 1, know who was there, not just as in workers, but that's oftentimes who we hear about because it's most convenient, but also as far as the general public. This goes into treatment, this goes into follow-up, in lesson 4, taking care of the affected people. Number 2, public health input. Bring in the experts, the epidemiologists, for help in tracking and setting up care of how to manage these people. Lesson 3, rapid collection of health and needs data. The information, the quicker you get that information, the sooner you can begin planning, begin setting up procedures and policies. Lesson 5, emergency preparedness, what we're talking about here. And then lesson 6, data-driven needs assessment and advocacy within a timely manner. And that ties into, again, lesson 3, rapid collection of health and needs data. So we're going to talk a little bit about the National Incident Management System. Mostly because it's a very, very, very important. Hospitals are also getting into this. There's a couple training modules within the FEMA website that people can get on that deal specifically with healthcare. So it's developed to outline the procedures for incident management, meant to be an expandable, collapsible system that is to be adjusted for the type of incident. So what you have a modular setup, modular design, which you can expand with larger operational periods as you need it, or it can be contracted as you have a smaller incident or you have an incident that is fluctuating in size and need of resources. So this is the idea is to have small teams with close supervision to complete specific tasks. And by doing this, you're managing your resources more efficiently and more effectively, and you're keeping track of what's being done and how they're being accomplished. So examples, I use this a lot in search and rescue, fire operations, police operations, military. Again, you can do this through the hospital. American Red Cross uses the NIMS framework as well. You can take these courses online. Specific courses to the healthcare operations, the hospital, IS 100 HCB. This is a video here that you can come back and watch. It gives you a little bit more information about the NIMS and National Response Framework. Here are some additional resources that you can go and look more information up. and these are my references. I hope this was an informative presentation, just kind of